In this project, I looked at diabetic retinopathy and the way the disease evolves, and then looking at different treatments, and most importantly, which treatment is the best option and the most cost-effective. This leads to the basic question of what is diabetic retinopathy? And it is a big deal because it is the leading cause of blindness among adults globally, and this is due to just the high prevalence of type 1 and type 2 diabetes. And what's happening is people within this population, diabetic population, have elevated blood glucose levels typically, and when this happens you see damage to blood vessels, specifically microvessels such as the ones found in the eye. And these microvessels will basically start to bleed or leak as damage is done to them, and when they do that they'll either thicken or they'll form new blood vessels and proliferate. So this can eventually lead to severe vision loss, or at least some level of vision loss if left untreated. What's interesting is often symptoms do not show up until the very late stages, such as PDR, proliferative diabetic retinopathy stage. So to treat this, there's two options. The first and more traditional option is panretinal photocoagulation, PRP, which is basically shining a laser into someone's eye. And this has been used for decades. Recently, a new idea has come into the scene using anti-VEGF agents, and ranibizumab is one of the anti-VEGF agents that has been studied and is the most commonly used. But basically, it's an injection that's supposed to stop the formation of these new blood vessels. So the question that this research study is looking at is which method is preferable, why, and what are the underlying dynamics leading to that conclusion. This table covers some of what we just talked about, but then also looks and sort of provides a preview of the remainder of the presentation. But the key takeaways here is this is a Markov model sort of underlaying a simulation model that was built in Simia. And the study simulates a cohort of 10,000 patients who start in a no diabetic retinopathy stage, but who have a predisposition due to having type 1 or type 2 diabetes, and it's simulated over 20 years. And the idea, based on the outcomes we'll talk about later and the cost, is that using a costing model, we can kind of determine best policies or best practices for the medical sector. The concept used to answer this question, as kind of was just discussed, is a Markov model that underlays the simulation. So the Markov model is built with the idea that there is a disease model that has certain states, and that left without treatment will ultimately lead to the absorbing state of severe vision loss. But it also has a treatment model that is overlaid, but it's also a Markov model in itself. In the sense that there are basically 5 treatment years, and then there are 2 absorbing states for post-treatment and adherence, and we'll talk more about that in a second. But the entire model is governed by transition probabilities. There are no decisions being made outside of basically these probabilities that are built in that are meant to model decisions. So the way that the answer is come to is through a costing model, as opposed to any other answers. And there are side effects reported and the numbers in different states, but the idea of the model is that we can look at the average cost of a patient at the end. And so the time interval for the simulation is a year. It is a discrete event simulation model. It's not continuously people moving between states, and that decision was made just to keep the model simple and to be able to govern it with the transition probabilities that were found in the data. Starting with explaining some of the inputs, and we'll start with states. So the disease model is built first. So the way it's built is there are non-proliferative diabetic retinopathy stages, or NPDR. And when you're in these stages, you can regress, you can progress into any of the later stages. There's PDR. And once you enter into PDR, you can no longer regress back into the NPDR system. You are either going to remain in PDR or you're going to move on to severe vision loss. And severe vision loss is an absorbing state. You cannot recover from that. Now, treatment is a sort of a separate model, and the connection is you can leave from severe NPDR or PDR to treatment. Treatment is built as a chain of 5 different years, and this is in line with the data that we have. So we have a 5-year clinical trial, Gross et al. 2018, which is where the majority of the data comes from, and treatment was occurring to the patients in this cohort for all 5 years, especially if you were in the IVR clinical trial. So it makes sense, and it's used as 5 individual years to model the cost more accurately as well as the adherence. And in the treatment, there are 2 absorbing states. So you're either going to enter into post-treatment after you finish all 5 years, or after any given year, you can transition into non-adherence. But for both of these absorbing states, you cannot return to the disease model. You remain in them. And this is just done to maintain the simplicity of the model, as well as because there isn't data to be able to model that. This is simply a diagram of the semio model that is built. At the top part, you can see the disease model that was just demonstrated. You can see the source for the patients coming in. And then you have the treatment model down below, and you have the two absorbing states, post-treatment and non-adherent. And you can see that there are connectors from PDR and severe NPDR to the treatment model. The next thing to consider is the transition probabilities that govern movement between the different states. For the disease model, two papers were used. There is Srikanth 2015 and the DCCT EDIC Research Group 2017. And there's two different data sets, and they were combined by using a weighting mechanism and basically multiplying Srikanth by about 0.25 and then the other one by 0.75, the probabilities in each of these papers to come together and define the probabilities from these two data sets with all the states provided. And then there is the question of transitioning into treatment. So to do that, there's two rates that need to be defined. The first is the screening rate. Basically, we know that not everyone's getting screened, especially since symptoms don't necessarily appear. So based on Lee et al., the screening rate was estimated to be about 60%. The second idea is that PDR people always are getting treatment, but if you're in severe NPDR, you're not necessarily getting referred to enter treatment. So there's sort of an arbitrary rate. There's really no data out there that I could find, but there's an arbitrary rate set of 0.6 to model this idea of if you're in this state, you may be suggested to get treatment. And then if you're in the treatment model, you're either going to continue or you're going to become non-adherent. And the non-adherent probabilities are governed based on the number of people that left the clinical trials, because that is reported year after year in the Gross et al. Papers. It's not the best data set, but there's really nothing else out there to be able to model this, and we wanted to get some idea of the concept there. Now on to cost, as the costing model is meant to determine the outcome more or less. So there's two sources for cost. The first is vision and visual acuities, and the second is treatment cost. So vision acuities are a way of converting less vision into QALYs and then using that QALY to model the cost. So we have letter scores reported from the clinical trial for all of the absorbing states as well as PDR and severe NPDR using their baseline data. And it's a letter score. So what's done is the letter score is then reported into an acuity like a 20/20, 20/15, 20/100 vision, whatever it is. And that's you. And then using that, there is a regression that was obtained from Ryan et al. That you're able to get a QALY score. And then assuming a QALY value of 50,000, you get a cost that it's lost. So anyway, then there's the idea of treatment cost. And so the treatment costs are coming from two sources. There is an expected value of operations based on the clinical trial data. And it's in line with basically the expected value calculations of Lin et al. 2018. And then the most expensive part of the operations is the number of injections given. And it's actually injections are given for both PDR and IVR. But to model that, a log normal distribution was used to introduce some stochasticity into the costing model. The last major input is side effects, and the number of side effects over the 5 years is reported in the clinical trial. This is converted to a 5-year probability, and then using the equation shown, that is converted into a 1-year probability. And then you can receive the outcome of the number of side effects. Most of these data sources were referenced in the previous slides, but just to have them here for reference. The only other addition is the treatment cost. The Medicare and Medicaid physician fee schedule was utilized. So moving on to the results. The three major results that were reported were, first of all, the number in each state to understand the dynamics over time and also the dynamics between the disease model and the treatment models. The average cost per patient, this kind of is the main determinant of which one is the most appropriate. And third, the simulation reports the number of side effects that are seen in the two treatment models. This table reports the final value for the number of people in each state at the end of the time horizon for each of the models. It also makes sense that IVR and PRP have the same values because the same random stream is used and the transition probabilities have not changed. The only difference is the costing model. It also makes sense that we see drastically lower numbers in PDR and SVL states, as you're not having people enter SVL due to the screening, and PDR being a state where most people stay in once they get there. If there is a screening introduced, people quickly get out of there and move into treatment. This is sort of the follow-up table to understand the dynamics over time. It's pretty straightforward. You do see that post-treatment starts rising much more drastically in the later years, whereas non-adherent rises a little more quickly. This makes sense given the treatment is 5 years. This table leads to one of the key conclusions of the paper, which is the fact that PRP is preferable from a cost standpoint to IVR when considering even visual acuities based on the assumptions that were made in this model at least. And you see drastically different results. This is in line with the cost effectiveness literature that has been done as far as using ICR ratios, so it's not surprising. What is surprising is that no intervention is significantly cheaper than IVR. If you look at this from a time horizon standpoint, you do find that PRP becomes more cost effective than no intervention at year 15, and IVR becomes more cost effective around year 25, which is pretty late. But this does make some sense given that there are much higher costs of treatment that people are incurring as they're incurring both treatment cost and vision acuity cost. It takes time for that number in SVL to rise to such a point that it's overcoming the extreme cost and the number of people in treatment that are receiving that extreme cost. So you're not seeing the results until later in the time horizon. This table reports the final outcomes for side effects. The two main things to note is that IVR is always less side effects except for envy of iris. This may suggest that even though the cost is a little bit different, IVR could be preferable from a side effect standpoint because the side effects were sort of modeled in the sense that the operations needed to fix them were modeled, but there's no vision acuity or quality score considered, so it could have some impact. For this presentation, there's not time to go through all the sensitivity analysis, but touching on one of the important things with the time horizon, this was mentioned earlier, but you see that crossover of disease model becoming more expensive than both treatments at year 25. And you also see around year 30 that PRP is actually increasing faster than IVR. So this may suggest if you really extend the time horizon, you will actually see IVR be the preferable method. So this concludes the presentation. There's certainly a lot more work that can be done, especially on the data standpoint. There's a lot of questions on things like adherence or on actually the number, the transitions probabilities could really be refined from collecting better data in future work. But the key takeaway is that there is some work on cost effectiveness, and this seems to be in line with that cost effectiveness literature. But this is the first paper known to the author that looks at this from a Markov model standpoint, that considers adherence and questions like that uses the newest clinical trial data, and also has a simulation model built in with it. So it's definitely a neat contribution, kind of furthers that argument that maybe we should be sticking with panretinal photocoagulation as opposed to moving on to the newer and greater treatment.